like Cindy said, I work as an adjunct professor here at Grand Valley. So I've been teaching here for 5 years, and one of the classes that I love teaching the most is the interviewing class. And how many of you all are SPs for either the interviewing class for social workers or for the master's, what is it called, individuals course? Or if you don't know the difference.
Probably everybody in the room either has or could work.
Okay, is it not just you do nursing and stuff too, everything? Okay, cool. So a little bit of what I'm going to present on today is how you all can present these diagnoses better to the students. Now, I absolutely love the SP program because back when I was in grad school and undergraduate, we didn't have this program. And so what we did was we did mock interviews with other students or scripted interviews. And they did not really do anything for us. We were able to practice the skills a little bit and get an idea of what it would look like, but we're doing it with a student that we know. Often they were very scripted. We knew what the issues were going to be, and we really didn't get a chance to practice it. The students love, well, they don't at first, but they love you all and what they get to do. And every semester that we do this, what ends up happening is, we meet once, maybe twice for class, but typically only one time, and then we come to the Sim Center and do the first interview. And they hate me, and they're mad at me, and they're anxious, and they feel like I didn't prepare them. Well, that's the point. We want them to feel that way, so we can get a baseline of where they're at before they have any idea of any of the skills that they're going to learn in the course. And then as the semester goes on, we're about to do our next one, and some of the papers that they're doing, I can tell they're starting to learn some of the skills we've worked on in class. They're starting to say they're excited to come back to the Sim Center and put some of them into practice. And then by the third interview, they feel really great. So that's an opportunity that I didn't have in school, and I can see how big of an impact it makes on students. And you all do a great job because they know, you're essentially a stranger and a paid actor, but it feels real in a sense, and that they can practice these skills not with someone who's just a classmate. So you all are so valuable, and I just want to say I appreciate that you take the time and are part of this program. Our students may never tell you, but they find it incredibly valuable, and we as professors do as well. So a little bit about me. Again, my name is Paul. I teach here as an adjunct. It's my 5th year doing that. I currently work for Mercy Health. I'm an outpatient counselor at their Heartside Health Center. So we're right at the corner of Wealthy and Division. So it's kind of a primary care office, but we also have outpatient counseling. So I work there, serving mostly the people in that community, in the Heartside community. But we also have, I have coworkers from other places, from previous coworkers, that's their primary care office, and that's where they also get counseling. So we kind of see everything there. Before that, I was at Bethany Christian Services for 6.5 years, doing counseling, group and individual in residential with teens from Central America, Mexico, and Africa. And so that was, now I'm doing outpatient. Back then I was doing residential, so I've kind of seen a little bit of those and how different they are, and they're very different. And then before that, I did some work at Pine Rest, Muskegon Community Mental Health. I lived abroad for a little bit. So I've been in the field for about 10 years, and so I've had a lot of unique experiences having worked in refugee, residential, and then now outpatient in the Heartside community, and then being able to teach as well. So a little bit of what we're going to talk about today is the way I'm going to kind of format it is I'm going to talk about these diagnoses that Cindy had asked that we discussed today. I'm going to talk about what the diagnosis looks like, and then how does it present? Because they're very similar, but they can be a little different as well. Anybody here have experience in mental health, as a mental health clinician, provider? Okay, okay, good. So the idea when we're looking at a mental health diagnosis, the part that really stands out is does this issue that you're having have a clinically significant distress or impairment in your social, occupational, or other important areas of functioning? So almost all of us have anxiety. Almost all of us have, some level of depression or sadness, or there are things that all of us struggle with. When we're looking at people that we're serving, typically in a counseling setting, when they're coming to see a social worker, coming to see someone for help or support, it's because it's gotten to a point in which there's some impairment in some aspect of their life. So it could be their anxiety is getting in the way of their work or their family life or their substance use or their depression. And so that's not always the case, because I work with a lot of people who are very functioning people. They go to work every day, they live their lives normal, but then they have kind of higher depression or anxiety than other people. But that's a lot of what we're talking about. A lot of what you all are representing to our students are, a lot of you are the court mandated person in your scripts, right? So you're there because the court made you after a DUI or something like that. And so a DUI is a great example of now there's some kind of clinically significant impairment. So, you're breaking the law because you're drinking and driving. And so that's an issue. And so a lot of what we're doing is helping people when they're becoming bigger issues than what they can maybe deal with on their own, or they just need some extra support. It's okay. So how we diagnose. So this is a kind of, and again, I know that you all are representing the client in here, but I'm backing up a little and kind of showing big picture because I hope it'll help as you begin to act these out for our students. So here's how I like to describe diagnosing. It's kind of a series of you're narrowing your view, you're widening it back out, and then you're narrowing it again. So what you're trying to do is you're almost like, one example I use of this is, so back in December, I was playing basketball with a group of guys that I play with, and I hurt my shoulder. And it wasn't bad, but it was enough that I was uncomfortable. Well, where I work, we have a physical therapist. So I went to him, I said, man, I got this thing in my shoulder that's really hurting. Anybody ever been to physical therapy? Okay, okay. So they have you kind of move it this way, move it that way, and what they're doing is they're figuring, okay, if this doesn't hurt, but this does, they're ruling out a series of issues. Then when you lift it this way and this way, they're ruling out other issues. And so we're kind of doing the same thing when we're diagnosing people, is that I'm kind of starting out and I start to narrow in on what I'm thinking it could be. I widen back out, and then I narrow in again. So an example of this would be, let's say someone comes in and I kind of have an idea there's some issues going on. Maybe they were court ordered or their doctor wanted them to come in. And they start telling me about they have some depression. So yeah, I feel like I'm depressed. I also feel like I have some anxiety. Okay, so I'm kind of starting to narrow in on depression and anxiety and what those issues are. And so I may kind of ask some more specific questions about that anxiety and depression. And I'm not just going to assume right away that they have both separate of each other. They may exist together. So I'm going to bring it back out now, and I'm going to ask some more questions to kind of get a more broad understanding of what I think the issue might be. And then I'm going to narrow in again. So, for example, I ask questions to clients. If a client has both anxiety and depression, I'll ask, do your anxiety and depression exist separately all the time, or can they exist together? And a lot of people say, no one's ever really asked me that before. I've never thought about it. But what I'm trying to figure out is, do they have an anxiety disorder and a depression disorder, or do they have depressive disorder with anxiety? And they're different, and we can potentially treat them a little different. And so that's what's really helping me kind of figure out, it's the same as that physical therapist moving those muscles to figure out where the exact problem is. So we currently use, in order to diagnose, the Diagnostic and Statistical Manual of Mental Disorders, the DSM, and this is the 5th edition. Anybody ever see this book before? Yeah, a few people. So back in, I don't exactly remember the date, maybe it was 2013 or 14, this one came out. We moved from the 4 to this one. And so this is like our Bible when it comes to diagnosing. And again, on almost all the diagnosis that we see, it'll say this is in there. This is for almost, for the majority of diagnoses, is that it's causing some kind of distress or impairment. And so you can see mine's all, tabbed out, and you can see I have OCD, right? So it's all tabbed out, and I know where everything is. And so that helps me, and I refer to this all the time. I'm using it as a way to kind of diagnose and see what, because there's so much in here, so I may forget to ask a certain question or try to see where I'm going. So that's what we use to do that. Okay, so we're going to start talking a little bit of what depression looks like, okay? So one of there's a few different criteria in the DSM, but there's one kind of major spot where it wants to know if they have any of these things for at least a 2-week period. So depressed mood most of the day, nearly every day. Diminished interest or pleasure in activities. So we call this anhedonia. So this is when maybe you used to be part of a knitting club or a book club or a sports team or a church group, and you all of a sudden have lost interest in that, and you don't want to do it anymore. We really want to clue into that. Weight gain or loss. Why do you think it could be both? Yeah.
Sorry, I was just swallowing. A weight gain because if you're depressed, you soothe. You do a lot of soothing.
Right.
So you eat. And weight loss because you have no appetite.
Right, so it could be both. Some people respond differently. Some people will eat as a way to cope with their depression, and they'll overeat, or maybe they're not active either, so they're sitting around more, or their sleep is off. And then some people just have no appetite, so they won't eat. So we want to clue into that. If I start to notice a client of mine either gain a lot of weight or lose a lot of weight, that's something I want to see, or I want to be clued into, I want to be paying attention to. Same thing, insomnia or hypersomnia. So not sleeping a lot or oversleeping, right? So some people, it is that they, when we see depression, they sleep all day, and that kind of makes sense. I think when we think about depression, we think of people who have no energy, they're always laying down, they're always tired. But it could also be that you can't sleep at all, or you have issues with sleep, or it's irregular. I have some clients who will say they sleep during, like they'll sleep 3 hours at a time, and then they're up for 5, and then they sleep for 2, and then they're up for 10, and then they sleep for 1. It's just kind of irregular. So psychomotor agitation. So this is, I want you to think moving slow. So again, the next slide will talk a little bit about how these look. But as we're here, a lot of times my clients with depression will walk in just kind of like, real lethargic, will almost sit lethargically. They're sitting, their movements are really slow, really tired, really worn out kind of look. Fatigue, loss of energy. Feeling worthless or hopeless, we really want to clue into this. And a way to really help students, I think this is a big one too, because for hopelessness, if I'm working with a client and they're not saying that they have hope in things, that's really important, because what do you think is more likely to happen if they don't have hope? Suicide, yeah. So that's something we really want to pay attention to. And you could be a young person with little hope when we look at teenagers and struggling with things that teenagers struggle with, but people in older adulthood as well. Life changes. Some of you do the empty nester training or empty nester scenario with students, right? And so that one's a good one too, where there could potentially be some hopelessness. Kids have moved on, maybe they live in a new state or a new place. There's not really much to look forward to. And so that's kind of a big one that we want to be paying attention to. If I can get someone to figure out that there's hope, that's like a lot of suicide trainings will be helping people find hope. So if I can get someone in a session to feel like there's hope, that they feel like they can go on, something to look forward to, that's a really big a thing that could help them not complete suicide and feel more positive. Difficulty concentrating is another one. And then reoccurrent thoughts of death, which again, that's a really big one to clue into, because we want to keep people alive and keep people safe. So when people are saying this, I'm definitely, and a lot of my clients I work with have had, I think a lot of people, more than we would when we realize in life, have had thoughts of suicide. But when I have clients who are really talking about thinking about killing themselves, that's a big hint that it's depression. It could be other things too. It could be other diagnoses, but depression is one I really want to look at. Okay, so how it looks. This is where, again, there's going to be a lot of overlap, but this is what it's going to kind of look like when you all are working with students. So again, the thoughts of suicide and self-harm, that's a big one. And our students hopefully will clue into that. Hopefully they've told you at the beginning of the session that everything you say is confidential. Unless you're going to hurt yourself or someone else, I have to keep you safe, and I have to keep that person safe. So, and then there are some other parts of that too. But thoughts of suicide, self-harm, that's a big clue for people. Moving slow, not much to say, generally tired. This one, when you're working with someone who's depressed, like I said before, they're kind of just sitting there. It's kind of hard to get anything out of them. I've seen a few of you do it in the scenarios, and you do a great job. So great work. Very kind of lethargic, slow. Well, I don't know. I don't have much going on. That kind of stuff, that's really good. And that's what we're looking for as we show our students what it looks like. Used to enjoy activities and you no longer do, or do not enjoy them while in a depressive episode. So this is what we talked about earlier, the anhedonia. So if you're talking with your students and you say, well, I used to really like to work on my car, and I don't like to work on my car anymore. I really used to do this thing, and you don't anymore. Hopefully, they're gonna clue into that. Or the other thing is that we're not depressed necessarily all the time, we don't have this anhedonia all the time, just when we're depressed. So that's a little. If you really want to be tricky with the students, you could throw it in where it's when you're depressed. It could be that 2 weeks out of every 3 months I'm depressed. During those 2 weeks, maybe I have this, and those other, 5 months and 2 weeks I don't, or however long I had said it. The other time you don't have it. So you could say, when I'm really depressed, or when I'm really down, I have a couple weeks every 3 months where I don't want to really do anything. Even the things I used to love, I don't really like doing them anymore. And then I might ask a client, well, when you're not feeling depressed, do you still like doing those things? Oh yeah, I really like doing them when I'm not, or when I'm happy. It's just when I'm depressed. Okay, using substances to mask the depression. So substance use is a big thing as well. So which is like what we were talking about with the overeating too. So it could be that they're using eating, and it could be there are all types of things. We can be addicted to anything. I mean, it could be shopping, gambling, sex, porn, drugs. It could be anything. But the working out. But it could be if we're seeing people using substances because they're sad. That's another clue. All right, is that in any of the? I don't know. In any of the scenarios, does that little piece fall in? Like people using. I know we have people who are there for a DUI and different things. Do we have anyone using because they're depressed?
Maybe not in the 316.
Yeah.
We go into the master's program, and now we're actually working with the substance abuse course in the master's program.
Awesome. Cool.
So absolutely.
Cool. Yeah, a lot of people start using drugs and alcohol because they have emotional problems. They have some kind of, whether it's depression, anxiety, or that's why they initially start using. Sleeping all day, not sleeping at all, no motivation. Present as sad or irritable, difficulty making decisions or concentrating. And crying. That's also a big one that I noticed people who are depressed will cry. Some people, I had a woman today cry, she actually said to me, she was crying, and I said, tell me a little bit about this, like the emotion you're expressing right now. Tell me about the crying. She said, it just feels good to have someone listen. Or she goes, I cry when people are nice to me. And so, and she works in foster care as a case manager, and so things are pretty crazy for her. So, just because someone's crying doesn't mean they're depressed. It could be they're crying for a multitude of reasons. But that's also one that we're cluing into when they're depressed. So, any questions about depression? Or ways that you want to show it better to students, or about the diagnosis itself? Yeah.
Body language.
Okay.
Posture.
Yeah. So let me get this chair. So you'll see like hunched. That's a big one that you'll see. Slouching. There's a difference between maybe like an angsty kid who's like, that's different. But you'll see a lot of like this, or I see a lot of this, like hands kind of like this, or, but yeah, a lot of kind of slouching, maybe leaning to one, head's kind of crooked, really that tired kind of look. That's typically what I see. If they're in the depressive phase, they may not be at that moment. They may be in a different phase. So, but if they're depressed, that's a lot of times what it looks like. Great question. Any other? Yeah.
One of the things I struggle with is, because the SPs all want to know, the students walk in and they're going to say, what brings you in? And what do I say? And do people recognize what this is? Do people just sit down and say, I'm really depressed and I need it, and that's why I'm here?
I'm willing to what? I'm sorry?
Your patients, when you say, you maybe have a better idea of what you see the patients for, but when you say, hey, also, what brings you in today, do they just look at you and say, I'm depressed? Or give us, can you
Yeah. That's a great question, and I've seen it. I've seen it a lot of different ways. So I'm trying to think of what's the best way for you all. As far as the depression one goes, I think there are some people who have been in the system their whole life, so they're really, people walk in, and we're going to talk about bipolar. People sit down all the time and go, I'm bipolar. And 70% of the time they're not. And so we're going to talk about that. We're going to talk about that in a little bit. That's the best one. I saved it for last. But depression, a lot of times people will kind of, if they haven't been in counseling before, or this is their first experience, they'll kind of talk around it. They won't, a lot of times won't say, I'm here because I'm depressed. They might say, my friends are worried about me, or people have said things to me like, you just don't seem yourself anymore, or ever since this thing happened, you've been different. They may say some of these, they may clue us into some of these things like, I'm just not as interested in the things I used to be interested in. I don't have energy anymore like I used to. And, you know, there are age-appropriate aspects of that too, right? Like naturally, just getting older, you have less energy than you did. If you're 70 and you're comparing yourself to when you're 20, then that's different. But if someone says, yeah, I'm not interested in doing anything with anyone anymore, those are the things. But a lot of times, if they've never been in treatment before and they're not very aware of it, they'll kind of talk. It's literally like they'll kind of talk around it, and you can see that depression's right there in the middle. But they're almost, and especially I think if some of you are working with students, as far as generationally, my generation is way more open to the stigma of mental health and treatment seems to be lower in my generation. I don't mean to generalize, but it just seems that way. And so when I've worked with older people, I've noticed it's a little harder for them to maybe admit that they're depressed. They may want to really tie it to one event that happened. And so people will kind of talk around it.
Did you notice a gender difference here? Maybe that's a stereotype.
No, yeah, that's a really good question too. So what's like some of our assumptions around depression with gender? Yeah, women have it, yeah. So why do you think that might be, why do you think we think that? That women have it more? Like,
Women can be more expressive.
yeah, women can be more expressive and talk about it more, right? Or more likely to seek treatment, right, than men. We're tough, right? We don't have depression, we're just struggling. We're just frustrated, we're not depressed. So I think I guess I don't know the actual statistics. I've read them before, I just can't remember them, but for me, I see just as many men as women. In fact, just in my practice, I probably just see more men. But a lot of times a lot of times people get misdiagnosed because if you're a man versus a woman, but I see it in both. Just women are more likely to get treatment and to be more expressive, yeah.
Also, there's just been a stigma, like you were just talking about,
Mm-hmm.
of ever saying out loud that you feel anything except something positive. And at least in my experience working in the field, you know, that has started to change.
Mm-hmm.
Families didn't want anybody to know that their son or their daughter or the husband or the wife or whoever, you know, was facing depression. You know, it's just, oh, well, he's just not feeling well. Or everybody's
Right.
always ready to come up with some other reason why somebody's sleeping all the time or
Mm-hmm.
doesn't want to go out anymore with the couples for dinner at night or whatever.
Yeah, and I think men, if you look at men like in crying, you know, stereotypically for a man to cry, it's way harder than for women. And so, yeah, men don't want to appear weak. I did research. It was, we were researching survivors of people who had completed suicide, and it was often men who had completed, and it was because they were depressed because they lost a job or their finances, or there was something going on that they just couldn't take the shame and the depression that came with it, and they killed themselves. And so, whereas women may be more likely to be expressive about that or seek treatment. Yeah.
Also has to do to the cultural. And, some cultures don't like to. There is a big stigma in some cultures. They don't like to talk about depression
Mm.
issues.
Yeah.
So that's why when they go to see the doctor, sometimes they talk about it,
Mm-hmm.
and or they think this is something physical.
Yeah, that's a great point. And spirituality and religious context can play a role in it as well. Yeah, in the back.
I just see what's good grooming in terms of like,
Grooming. Yeah. Yeah. Great point. Yep, that's another one that we would look for. Yeah, that's. I'm glad you brought that up. Yeah, a lot of times we call those ADLs, activities of daily living, and so people who have more depression a lot of times won't maybe bathe as much or aren't taking care of their health. And so that's one of the questions I ask on all my assessments. I say, you brush your teeth every day with any, are able to shower every day, any difficulty with that? And so if people, say they're not showering very often, I'm trying to think, are they depressed? Or sometimes I have people who have developmental disabilities and then don't realize they need to shower, more often. And so that's a great point. I'm really glad you brought that up.
What is the difference between anxiety and depression?
We're going to get there. Anxiety is the next one we're going to cover.
Oh, okay.
Awesome. Yeah.
Just to kind of complete that, there is no, well, I guess I'm asking about socioeconomic. When I have to cast all of this, and I used to think, you can look around the room, and we have our SPs who are always just, and I'm like, they can't be depressed. And then I'm like, Cindy, that's a mistake, because depression doesn't know any of this. And then I read some data about professional women being such at risk for depression, and they're not what I might typically be thinking is that depressed.
Yeah. And we're the most depressed country in the world, I think. I was just reading in a book. I think I have a book. I'm reading a book right now. I think I have it, and it was talking about how, like, a lot of times in cultures like ours, that where we have plenty, and we have, and that's not everybody's experience, but where we have extra stuff and we have a lot of resources, and that we're actually more depressed. Part of it is there's research on we live less in community, we're more isolated, some of that. And so the other thing is that you brought up about age or different groups of people is, has anybody ever heard of the ACEs study, Adverse Childhood Experiences? So this was done by the Kaiser Permanente group in California. I think it was in the 90s or late 90s, but they basically took a bunch of middle-class Americans with health insurance and had them take this survey that they created to see if they had a trauma in childhood, essentially. So it could have been, did you have a family member incarcerated? Were you abused? Were you ever, did a family member use alcohol or drugs? Were you ever sexually abused? And they found that in that group of people, 2/3 had complex childhood trauma. So if 2/3 of those people had complex childhood trauma, what could we assume about maybe people who don't have health insurance and don't have access to resources? Would that number be lower, the same, or higher? Potentially higher, yeah, it could be. But it leaves us to reasonably assume that 2/3, if you're in any room, in fact, when I do the training on the ACEs, I hand it out and have people take it anonymously, and then I tally it up, and typically it's 60-some% of people in the room have had complex childhood trauma. And what the ACEs study found, there's this beautiful pyramid they created where it shows, like, you have an adverse childhood experience, which leads to like emotional instability or emotional problems, which leads to high-risk behaviors, which it could be promiscuous sex or drug use or self-harming behaviors, which leads to the likelihood of disease and or health issues. It could be, you smoke so you have COPD, or it could be that you use needles so you get HIV, and then early death. So what the study found was there was a correlation between childhood trauma and early death, and it doesn't discriminate. 2/3 of people have childhood trauma. Yeah.
Therefore, if we present as a depressed person in our SP endeavor, should we briefed afterwards or get secondary depression?
Could you? Yeah, you could get some secondary trauma. Yeah, make sure you're taking care of yourselves after these, because they can be heavy things to do. And that's another thing. As part of the ACEs training, we train on secondary trauma, vicarious trauma, those kind of things, which are very real for healthcare professionals. Any other questions? Yeah.
Is it too early yet for studies, or like you see so many of the younger kids being socially interactive? Has that?
Like social media? Yeah, there's a lot of studies on that right now, and I'm not up to date on them. I've heard a few, I've read a few, but it sounds like the answer is yes, that it's really affecting people. There's this kind of where I was saying earlier that we're very isolated kind of people. We're not connected, and we're less isolated, but we're more isolated than ever with technology. And then the whole issue of how people present online is so different. You know, they only pictures they post are these beautiful vacations, and you know, I do that. I mean, I don't. It's like I post these great vacations. Well, I'm living, you know, 300 other days a year that can be, you know, can be very different than those. So mine's not awful, thank God, but it could be. But you know, so you're constantly comparing yourself. Yeah, that's the social media thing is going to be a big point of research. All right, so we're going to move into just a quick discussion, maybe just a couple minutes, but maybe with a few people around you, however it's easier to group up. Just maybe talk about the ways maybe you've exhibited depression well as an SP, some of the things you've done well, and maybe come up with one or two things that you can work on in the next time if you end up doing it. Maybe you're not one of the people who has done it, but what would you do or what could you do? So I'll give you, yeah, maybe like 4 minutes to do that, a minute per person maybe, and then we'll come back. I'll bring us back in 4 minutes. All right, we're going to move on to anxiety now. I love it. It's good. It's actually really good. I planned for that. I ended 30 seconds earlier because I figured. So good. It sounds like there was some good dialogue, some good discussion in there. So I heard someone say takeaway. It's good to have a couple takeaways. I know you won't remember the whole presentation, but there's a couple things you can remember and take those with you. It'd be great. All right. So now we're going to talk about anxiety. Okay, so what the diagnosis of anxiety looks like. So again, we're going back to that part from the beginning where it typically is causing some kind of clinically significant issue in your life or distress in your life. So that goes with all of the disorders. But anxiety, some of the key components are excessive anxiety and worry occurring more days than not for at least 6 months. So, you know, we try to be aware of the fact that if someone has a big promotion coming up at work and they've been anticipating it for a month and they're not sure what's going to happen and they're really worried if they're going to get it or not, they could have a lot of anxiety about that. I don't want to minimize that, but it may not necessarily be something we would clinically diagnose. If it was about something specific for a short period of time, it could be more or less a situational thing. It could be someone has anxiety all the time and then it spikes when stuff like that happens. So we kind of want to look at the whole holistic person to kind of figure out what's going on. But typically we're looking at 6 months or more. And it's really difficult to control the worry. So some of us maybe can distract ourselves when we're feeling anxious, or we just do something else, or we work on the thing that's making us anxious, and once we get it done, we feel better. But typically it's difficult to control that level of anxiety and worry. So symptoms can include restlessness, feeling keyed up or on edge, being easily fatigued, difficulty concentrating or mind going blank, irritability, muscle tension, sleep disturbances. What does that kind of sound like? Depression, right. So it's tricky. So we have to, there are a lot of elements. That's why we're narrowing, widening, and narrowing. Because a lot of times clients will tell me, and we're going to get to this with bipolar, where there are elements of that could be in 2 or 3 other types of diagnosis. So I have to really pay attention to the subtle things. And so, but this one, typically I find that people are very aware of the fact that they're anxious. So Cindy, you had asked about depression, like do people come in and say I'm depressed? I find that people come in more likely to say they're anxious than they do depressed. So that just seems to be the case. And so these are a lot of the things that we see. A lot of times with the anxiety, you won't see that person being as lethargic as you do with depression. They're maybe not necessarily feeling down and in the dumps and slow. Sometimes people with anxiety are going really fast. It could be a mile a minute, which we'll get to in a second too. So those are some of the main things that we would see. So a note on anxiety, and this may not be super important for you all in being SPs for our students, but I wanted to bring it up. There's anxiety has several different, it can be a bunch of different diagnoses for anxiety. And so there are 2 that I want to touch on, or well, 3. So we're kind of talking about general anxiety, generalized anxiety. But here are 2, 3 more, I guess, so there's 4. But agoraphobia, so this is anxiety and a fear about public places, and this is fear of being trapped, which is different than social phobia, which is similar, but the fear is about being judged or scrutinized by other people. So narrowing, widening, narrowing, okay, when I'm making a diagnosis. So I'll ask a person about their anxiety. They say, yeah, I have anxiety. So, well, tell me what makes you anxious. Well, I get really anxious about riding the bus. Okay, tell me about what about the bus is anxiety provoking? So I'm asking open-ended questions, right, which I hope my students are asking you. If they're not, they should. We're gonna keep working on it. And so I'm asking them open-ended questions, and they might say, well, I don't like being on the bus because if I have to get out, get away, I can't. Okay, so now I'm thinking, I'm narrowing agoraphobia. If they say, I don't like to go to church, I can't be in church anymore, I don't like going to church. I'll say, well, tell me why you don't like to be, what about church is hard to be in? And go, well, I feel like when I'm there, everyone's looking at me and they're judging me, and that I don't, and that they're gonna figure out that I've done these bad things in my life. I work with a lot of people who are on parole or have been in prison for sex crimes, criminal sexual conduct, and I have multiple people with that like history who also have social phobia. They're afraid of going to church, or they're afraid of going to the mall and people are going to know that they sexually abuse a child or something like that. And so, but they're different, but they're both anxiety about social situations, but the reason they're anxious is different. Does that make sense? Is there any unclarity about that I could resolve for anybody? Okay. And then panic attacks, well, we've probably heard of that. So you can just have a panic disorder where you have panic attacks, or panic attacks can be like a modifier you stick onto any of these. So I might diagnose someone with generalized anxiety disorder with panic attacks. So, but I like to talk about it because this is a good one too to show like students potentially. I don't know what all the scenarios are, but this is one where people have heart palpitations, pounding heart, sweating, shaking, shortness of breath, feelings of choking, chest pain, nausea, dizzy, chills, or heat sensation. And these typically come on pretty quick, and some people can have them as short as an hour or less. Some people have them prolonged. Kind of depends. Yeah.
So are you
Yeah.
saying that panic attacks, all of these are the symptoms of what they look like for the panic attack?
No, just the panic. These right here. These are just the ones under panic attacks.
Right.
Now you could have versions of these in like just regular anxiety. Like I may get sweaty before I know I'm going to go do something that's anxiety provoking. But typically these are very, like the choking, the chest pain, the shake. Like I have clients who, when they're having a panic attack, will like do this. Like they're really, like you can tell they're just like pacing, and some people think they're having a heart attack. So which is different than just if you have kind of general anxiety. Did that answer your question? Was that right? Okay. Yeah.
A quick anecdote from the question.
Perfect.
I had a panic attack about 10 years ago.
Mhm.
I do not recall having anything that triggered it.
Yeah.
It just kind of happened. I was with family. I was going somewhere, and it hit me. It just kind of dropped on me. Is there generally some kind of a trigger, whether you're aware of it or not, that triggers specifically a panic attack?
It could be, and it might not be too. If you don't mind me, asking, do you carry like a low level of anxiety typically, or no?
I used to. I don't as much anymore.
Okay. I'm similar. The older I get, I feel like the less anxiety I have. I used to have a lot more anxiety when I was younger, and I have less now. And I just one time in the middle of the night woke up with a panic attack. I don't think I've had one since, and I was sleeping. Now I did have something coming up the next day. I had 3 major changes happening the next day, and so something about my brain was active at night when I was sleeping. But I wasn't thinking. I didn't think myself into the panic attack. I just woke up with it.
So could it be chemical?
Yeah, I think so. I think all of these are. I mean, a lot of these are chemical. A lot of mental health disorders are chemical, in my opinion, and that's what the research shows. Now we can treat them with medications that help with that, with the biological aspect or the chemical aspect. But a lot of the treatments I do are ways that we can go after the thoughts that make us anxious. So a lot of the anxiety I had when I was younger was related to the way I interpreted my environment and the way that I saw things, or the way that I was worried about the way that my thoughts, I had these negative thoughts about stuff happening in my life, and so that was creating more anxiety. When I started handling those, that anxiety went down. But there is this like natural component. Even sometimes I'll be taking a nap and I'll just wake up anxious. I have nothing to do that day. I don't have anything going on. And so I think there's definitely a chemical kind of aspect. But someone could also say, yeah, your brain was thinking about stuff while it was, I have a lot of clients who say they don't get anxious till they lay down at night and go to sleep. I think it's because they finally slow down enough that their brain starts to throw out some of that stuff that they've been that they've been kind of repressing all day. Any other questions about? Yeah.
Would, maybe in the cases where they say you were forced to be there by the court or whatever, so you don't want to, did somebody ever stage something like that to not have to answer questions, and have you ever seen that?
Yeah, I think I have seen that. People will, so some things people will do is they'll talk about diagnosis they've been given in the past, and the bipolar is a big one, so we're going to talk about that next. I do think a lot of times people will focus on other issues to not really deal with what's really going on. So maybe some people are willing to, especially if they're court mandated. So I've had a lot of patients court mandated for alcohol. The one thing they don't want to talk about is alcohol. Or anger. They're there because of maybe domestic violence, but they don't have an anger problem and they're not an abuser. It just happened one time and they don't want to talk about their anger. But I know how to get there, kind of come around the back door, but there's a way to get there. But yeah, we do see that. People will, especially I think too, some people, if they have a stigma about depression and that kind of stuff, they don't want to come off as depressed. Yeah, Cindy.
Is this fast where depression is slow and not necessarily?
Typically, that's what I see at least. I see a lot of people, when people are depressed, and again, I know there's also ADD and ADHD, there's all that can be thrown in, but a lot of times people who I know that have anxiety are a bit more fast-paced with stuff. Even just as they're sitting in the chair, they're not slouching stuff like depression, but they're moving a lot of times a little bit quicker. Or some people aren't even moving quicker, they just, they're not lethargic, they're not kind of down in the dumps about it, But some people are really fast, they're really like, kind of, and then I did, and then I go to this, but I get really anxious when I go here because, I see that too. Any other questions? We're going to talk about how this presents a little next. So how it looks. So there can be a lot of crossover with generalized anxiety and other anxiety disorders. So that was a little bit of what we talked about with the agoraphobia and the social phobia and panic attacks. And so there's, for you all, it's not going to make a huge difference, but that is something that we kind of have to be aware of that I feel like it can be hard to really nail down an anxiety disorder because they sometimes can cross over. OCD is another one that we'll talk, that is down there at the bottom. So sometimes OCD characteristics, like wondering if the stove or water is off. So that's a way that you could present that in, who does that? I do that. I got that problem. My car's locked, right? So now what I do is when I lock my car, I say brown shoes. And then like later when I see my brown shoes, I'm like, I locked the car. I remember. So you've learned some of those tricks over time. But there are some people who have OCD, who have obsessive compulsive disorder. That's an anxiety. That's a disorder that'll be a separate diagnosis. But there's a lot of people who have anxiety, general anxiety, who have some of these symptoms. That's what I mean. There's some crossover between them. Does that make sense? Yeah. So you may not fit the diagnosis for obsessive compulsive disorder, but you have some of those traits because it's an anxiety-based disorder. So another way to present is worrying about things that maybe most people don't worry about. I have a client that I'm currently seeing. I think he's 56, and he's been in and out of prison. He's been out for a couple months, so he's coming to see me, and he has a lot of anxiety. And it's more, I think it's more of the agoraphobia. But he has a lot of anxiety. He takes the bus to come see me, and a half hour or an hour before he leaves, he starts getting anxious, and he starts sweating. And he's like, I got to walk to the bus. He's got a lot of pain in his body. And he wants pain meds that our doctors aren't willing to give him because they're narcotics, and he knows they work for him. And they do. I believe they do. I believe that, that Norcos and stuff, they work for him, but he can't get them. So, and he doesn't want to do our pain clinic, which we have to do physical therapy. So so he's got pain. So walking to the bus stop, he's worried about, is the bus going to be there on time? And he's worried about how long he's going to be standing there. Is he going to slip on the ice on the way there? And then he doesn't really like the bus drivers because when they're really touch and go with the pedals, it hurts his back and he's in a lot of pain. And so he ends up, before he comes to see me, he says, I was wringing with sweat before I came to see you today, Paul. And he'll wear a wool hat to kind of soak up the sweat. And so that's kind of like worrying about things that you would say most people in general wouldn't worry about, right? It's like, some people are like, well, the bus gets there when it gets there. I get there when I get there. He also has to be super early, and he has to be like a half hour early. And so if he's not, it creates anxiety for him. And so other people are like, I get there when I get there. And if I don't, I have other clients who are like, well, if I don't go, I don't go. They don't care. So for him, he worries about things that a lot of people really wouldn't think too much about. So again, fear of taking the bus, being in public spaces, again, crowdedness, when you think of a little bit of that claustrophobia. But in the bus, a lot of times, it's a lack of control. My father-in-law, I shouldn't say this is recorded. But I will anyway. My father-in-law he had his pilot's license a few years ago and had a single-engine plane that he would fly and loved it and really enjoyed it. But when he flies on commercial planes or he flies with other people or rides in cars with other people driving, he gets kind of anxious. And he said that he was in an elevator once with a psychiatrist and it came up somehow. And he said, yeah, I get anxious when I'm with other people. I can fly it, but when I'm with when someone else is flying the plane or driving the car. And the psychiatrist said something like, oh, you don't have this problem. You have a control problem, right? And so we see that a lot of times with people who have a fear of taking the bus, that they're not in control, they're not the one behind the wheel, they're not driving, and so there's anxiety around that. Yeah, everyone, don't point to your spouse. Okay, and then we talked a little bit about the OCD stuff too. So, okay, any questions?
Does this come from somewhere? I mean, you talked about the biochemical thing. Is there, where does this come from?
Good question. So there's a chemical aspect. So it's always this kind of like nature versus nurture debate. And so a lot of anxiety can come, I think, chemically. It can just be kind of how you're built, but also depending on the environment that you're raised in. So I was meeting with a client today whose parents were very critical of her, very critical of her work. Everything had to be perfect, couldn't be any mistakes. She comes from a traditional Chinese culture, and she's like, now she has a ton of anxiety about getting her work done and it being okay. Is it perfect? So she's like a really big perfectionist. And so it can come from that. There's theories too, like for example, and we were talking about this with her today, like if your parents are abusive, you can come to, like if your parents are always abusive, you can come to expect that they'll be abusive. And can almost be easier for children than parents who are sometimes abusive and sometimes not. Because you don't know what you're going to get today, and that creates some level of uncertainty in a child, and they can't really know, they don't know what they're going to get, and so the world's not safe, Even if that parent's not safe, they know if that parent's 100% not safe, you avoid them, and you know what you're going to get. So that's, that can be part of it too. Yeah, those are the big ones that I see. Yeah. It is, I do believe in the chemical. We always ask people, is there a history of mental health disorders in your family?
And how often is it exercise?
70, a lot. It's a high number, and it's probably maybe 70%, but I bet it's higher. I bet that the parents weren't willing. They never talked about it. If I'm working with a 65-year-old client whose parent was born 30 years before them, that may not have been a time where they were willing to talk about it. Or we look at people who came back from World War II, right, when they called it shell shock. Before that, it was battle fatigue, right? It's trauma. That's what it is. It's trauma. So, all right. So, yeah, we did. Did we do this? No. Okay. So, again, worrying about something minutes or hours before it happens. This was kind of like the client I was talking about with getting on the bus and coming to see me. Shaking legs in the session and moving a lot. So that is another thing I see. And it doesn't mean you're an anxious person. It could. But it's not always the case, but I see people, bouncing their legs a lot. You all can't see, sorry, but, bouncing a lot or tapping a lot. Some people just move a lot, so it's not necessarily, or I have a client with Parkinson's, so I'm not assuming it's anxiety, it's Parkinson's. So, but yeah, you'll see a lot of that moving and ticking not ticking, but yeah, moving. And again, this could also be attributed to ADD or ADHD symptoms as well. So, awake at night, worrying about various things. So a lot of times people with anxiety will be up at night just thinking about things, going through their head of like what happened that day, what could have been better or worse, or what are they going to do the next day, and then that racing thoughts, just a lot of thoughts coming and going, just a lot of stuff coming in and going out, and not being able to really follow one for a long time, which could also be ADHD, but it's a tell-all for anxiety as well. Okay, so same thing we did with depression. We're going to get in groups and talk a little bit about the ways in which you've exhibited anxiety well as an SP and some things you can improve. Maybe have 1 or 2 takeaways. And we'll do another 4 minutes on this one. Now we're going to get on to the really interesting one that I imagine a lot of people are curious about, is bipolar disorder. Actually, before we do that, 2 things. Number 1, what were some of the takeaways about anxiety that people came up with?
We all have it.
Yeah, weird as I get. We all have it, yeah. And I was telling them, when you get into this field and you're studying all these things, you start to realize, you start to diagnose the people in your life, you start to diagnose yourself, right? Yeah. Oh, yeah.
One of the things this nice woman suggested was going on YouTube.
Mm.
And,
About the behaviors, look on through YouTube, anxiety and panic attack behaviors.
Oh, that's a good idea. See what they look like?
Yeah.
Yeah, good idea.
Well, I'm about it.
Yeah, it's a good idea. Anything else? Any other takeaways? Maybe one more. We'll hear from one more person. Yeah.
Just a question about bipolar. Is the same bipolar than different personalities? Double personalities?
Yeah, they're different. Yeah. Any other about anxiety? One more takeaway from anxiety that what we're going to apply as SPs. Yeah.
Well, not to some extent, because I observed in a 20-year-old young man who's lost his boss for 30 years. He exhibits every anxiety symptom, anxious,
Mm.
lost, constantly moving,
Mm-hmm.
anxiety for 7 of us.
Interesting. Yeah. Thanks for sharing that. All right. So, yeah.
Did I get it right? You said there's a lot of crossover between depression and anxiety.
Yeah, a lot of these, especially these symptoms here, these on the bottom, can sometimes be on both. So restlessness, easily fatigued, feeling tired, right? They can look very similar. Difficulty concentrating can be in both. Irritability and sleep disturbances.
What's the greatest difference?
Great, yeah, that's a great question. The major difference is the worrying, like excessive anxiety or worry. I'll take out anxiety because that's in the definition. I'll say excessive worrying. That's like a big thing. Is people who are depressed aren't necessarily, they could be, but they're not necessarily worrying all the time about stuff. People who are anxious are worrying. Racing thoughts is another one that I see a lot of. That's just a lot coming in and out of my head. So, yeah.
You've heard in the past somebody say that if it was anxiousness, you'd have a hard time falling asleep, and depression would be if you woke up in the middle of the night with all those thoughts and everything. Is there?
I haven't heard that, but it could. I mean, that could be the case. So you said if you have anxiety, it's hard to fall asleep.
Because you're so anxious,
Mm.
can't settle.
Yeah, and settle yourself. Yep. Mm-hmm.
But it would show. It would be depression if you wake up in the middle of the night.
Oh, and you. I don't know. Do you know where you heard that?
It was on a radio talk show years ago.
I bet you that is true, and that it could go both ways. Because like what we were talking about is like it could wake up out in the middle of the night and have a panic attack. And then some people with depression can't sleep. They have the kind of hypersomnia. So I imagine it could be both, which is why it's so tricky with this crossover. That's why we're really, And again, we have our Bible, so this really helps me. So I have it, right here tabbed. So excessive anxiety, worry, occurring more days than not for 6 months. Individual finds it difficult to control the worry, associated with 3 or more of the following symptoms, which are these symptoms listed. It's not caused by something else going on. It's not caused by a health thing. So I open this a lot and really look at it. I mean, almost every time I diagnose someone, unless I'm really clear on what it is, just after the session, I'll open this up and be like, okay, just take a look to make sure that I got it right. I saw another hand. Yeah? All right, I'll tell you what I think the difference is. And this is just, the world according to Paul Kiger. But imagine that you're sitting next to a road and your one job is to just watch the cars go by. Now you can have a hammock and sit with a cold drink and just relax and watch the cars go by. That's all you gotta do, watch them go by. You might see one that reminds you of being a kid, your dad's car growing up, or you might see one that you think you'd like. A lot of times and then imagine that you can't sit there and watch the cars go by and you have to chase all the cars. And you can't just watch them go by. You gotta get up and they're going by and this one's going by and this one's going by. I gotta go, I'm gonna chase. And essentially the cars are thoughts. Can you sit down and have thoughts where you think through them, you can settle on one thought for a long time, or are you chasing all the cars? Which could also be ADD or ADHD, but anxiety. Okay, good. All right. Anything else? Any others on anxiety? Okay. Okay, so bipolar. So this used to be called manic depressive disorder. So maybe some of you have heard that. And that's because you have a manic phase and a depression phase or depressive phase. And we're going to talk about the difference between those. So many people are not bipolar, but they're misdiagnosed with bipolar disorder. Anybody have any guesses why? It's tricky. So I have some theories. One of them I think is when this diagnosis, there was a time period, it might have been in the late 90s or in the mid 90s, but it started becoming like a bigger diagnosis that people were using. And I think there was just some misunderstanding of the diagnosis. But also, from my understanding, from what some people have told me, is that it was a way to get treatment paid for. So if you had treatment could get paid for if you had a bipolar diagnosis. Now, that's not ethical to diagnose people just to get treatment paid for, but people need treatment. And so people probably had good intentions that they wanted someone to get treatment. And if you had a depression diagnosis, maybe you couldn't get into treatment. It wasn't severe enough. Or if you had an alcohol use disorder, you couldn't get into treatment, but you could with bipolar. So that's one reason that was misdiagnosed. And so I think, and what it's kind of caused, it's caused kind of a lot of problems with clients. I've had a lot come in and say that they're diagnosed with bipolar disorder, and they're typically people who got that diagnosis. Again, I can't remember exact time. I think it was sometime in the 90s, could have been early 2000s. But they said they'll come in and they'll say things like this. Well, I got into a fight with my wife one day, and the police were called. And when the police got there, I'm bipolar, and I got all manicky, and they'll shake their hands. And I got all manicky, and I fought the police, and then I was taken to jail. Well, that's not how manic works. You don't just get manic because someone showed up at your door. You either have anger problems, you have another disorder. It could be like there's one for, I think it's intermittent explosive disorder, so it could be something like that. And a lot of times what it is people are detoxing from drugs and alcohol. And they're up and down, their moods are all over the place. One example of this, and I can't 100% say what it is or isn't, but do you remember it was in like 2012 when Charlie Sheen got fired from being on that show? What was the name of that show? 2.5 Men. If you watch interviews with him, you're like, whoa, he is all over the place. And I think there was talk about him being bipolar or manic depressive. He might be. I'm not saying he's not. But I really think what was happening, I think he was detoxing from cocaine, or you know what I mean? I think there was, or from something. I think there was. And so a lot of clients will go into the hospital detoxing from something. And this would also make sense if it was happening in the mid-90s, because crack cocaine hit big in the early 90s. So there could be some correlation there. That's just my theory. And so, you know, it really is, I think, a lot of these other issues, but people think that they're manic depressive or bipolar. Okay, any comments or questions about that before we move on? Yeah.
So in the 90s, I had an accident. I had before fibromyalgia was known.
Okay.
So I had been given all these medications, and I was, I guess I was diagnosed with depression.
Mm-hmm.
So I was given antidepressant medication. So I was in bed for a lot of years, taking medication. So the doctor finally could give me more. She couldn't increase my dosage. So she sent me to a doctor, and he did questions and analysis. And I think, like you said earlier, that at that time you could get diagnosed as bipolar, so
Mm.
that I could have gotten Social Security.
Yeah.
And that was what the doctor said, because I don't see any of this, but I can give you, I can diagnose you this way.
Mm.
The insurance will pay for it, and you'll be all taken care of. And I said, he says, is that what you want? I said, no. I said, there has to be something. And sure enough, he put me on different medication, and it was like night and day.
Mm.
And so yeah, I remember.
Wow. Well, I give you a lot of credit for telling that story in front of a group of people, but also your courage to stand up to a psychiatrist. It was a psychiatrist or psychologist? Either way, if someone came to me and had seen well, maybe not a psychiatrist, but if they had gone to a psychologist or a psychiatrist and they did some kind of testing, I would probably defer to that diagnosis more than I would someone else. So the fact that you say that shows me not to do that, because that could have been, you know, and a lot of times I'm working with clients who got in to see mental health professionals starting in the 80s or 90s, and so maybe maybe this diagnosis has been attached to their file this whole time, but they really don't have it. Thanks for sharing that. That's really helpful. So part 1 is a major depressive episode. Oh, speaking of depression, I was talking with Cindy at the break. Another thing about depression when we're looking at generations is I have a friend who has depression, and you know, he's from Singapore, and they also didn't talk about depression in his culture. And he said his grandfather used to say things like they'd be at the dinner table and he would sit down to eat and he'd be like, well, I don't really want to eat, but I have to be good to my stomach. And so the grandfather didn't have an appetite and was depressed, but knew that if he didn't eat, he'd get sick, and so he'd eat. So that was like a way he kind of clued in that his grandfather was depressed. So that was another generational thing. I forgot that. But when I saw a depressive episode, it reminded me of that. So bipolar has 2 parts to it, essentially, when we kind of boil it down. There's a major depressive episode. So this is the same as what we talked about earlier with depression. So we already know half of it. It's going to look very similar to depression. And then the next part is the manic or hypomanic phase. So what this normally is abnormally and persistently elevated, expansive, or irritable mood. So people are very, very happy. People are typically have a lot of, so we see these things, inflated. I'm asking these questions as I'm narrowing, widening, and narrowing. So inflated self-esteem, decreased need for sleep, more talkative, racing thoughts, which we talked a little bit with anxiety, distractibility, increase in goal-directed activity, either socially, at work, school, or sexually. I've known people with bipolar disorder who will stay up all night and get a project done that they've been putting off for a month, or 2 months, or 3 months. Up all night, working on it. Wouldn't believe the amount of creativity, the amount of how different it is than it would be if they were depressed or if they weren't manic. Excessive involvement in activities that have a high potential for painful consequences. So unrestrained buying sprees, sexual indiscretions, or foolish business investments. So this can be really difficult for us because some of those don't sound that bad. And some people like being manic. And so we have to do a lot of education with people who like being manic because typically the consequences outweigh the benefits. So that night of partying at the casino and shopping spree was a lot of fun, but now you're broke and have no money. So it kind of creates some issues. But a lot of times people really like how they feel when they're manic. Hypomanic is a less, that's what I'm thinking of, not as strong of a version of manic. So it's not as intense as full manic. So and I'll show you a chart, it's in the PowerPoint in a minute, whereas manic's like really high and hypomanic is not quite as high. It's a little lower. A little bit more able to function if you're hypomanic than if you're manic. People who are manic, they'll do things, you'll see, like people will empty their bank accounts and move while they're manic. They'll just like pick up, I've always wanted to live in California, empty their bank account and go. Not everyone does that, but you can potentially see things like that. Okay, so here's how it's going to look. So having a lot of energy, less need for sleep, that's a big one. And before, and again, less need for sleep, but they're not, and when they're manic, they're not depressed, right? So if you're depressed, maybe you're sleeping less, but it's maybe because you can't sleep when you're depressed. This is, you're having a lot of energy, you don't really want to sleep, you don't need to sleep. Feel very happy or elated. More artistic, musical, etc. I knew someone who had hypomania, and they would just stay up at night and write songs and paint, and wouldn't do that when they weren't hypomanic. Just, I mean, it was stuff that they wouldn't typically be able to do. More promiscuous behavior, a lot of times that's not typical of the person. So people can be promiscuous and not have mania, but typically if they're manic, it's more than what they would typically be comfortable with if they weren't manic. Going to the casino and spending a lot of money, that's kind of a tell-all. Now, again, or can you go to the casino and stop? You also look at addictions here and gambling, but when we're looking at it again in the context of this disorder, this is something that we see. And then spending money on shopping or other items, or money you don't have, is another thing. Okay, I'm going to keep going on this one. So, all of a sudden getting a lot of work done at school or at home, especially if there was depression before that. If I see someone who's depressed, is a depressed person, and then all of a sudden I'm seeing these things, it's really cluing me in that there's potential bipolar. Yeah. No, so great point. So you can show up as manic in the session if you want. I don't know how these all play out, but you could show up as manic, you could show up as depressed, you could show up as normal, but hopefully, if the student's asking the right questions, they're going to get that history. So I've had clients show up in a manic phase, and it's a little easier to know that they're manic, but I have other clients who show up with bipolar who are depressed, and so at first I'm thinking, okay, this person has depression, and I always ask the questions when I'm doing an assessment. I say, do you have a week or 2 weeks or 3 weeks at a time where all of a sudden you're not depressed and you have like a lot of energy and you go out and spend more money, and that gives me a clue if they're. And I'm not really teaching my students in 316 in the undergrad version to ask those questions, so they may not be asking you, but hopefully they're asking you good open-ended questions just about you in general. But you could clue them into that stuff. Yeah. Let me go to my Bible. They can be different. I think that the hypomanic is typically shorter. I think it's a week or two. So manic is lasting at least 1 week and presents most of the day, nearly every day. And typically the thing with a manic episode is it's affecting your life so strongly that a lot of times you'll need to go, and you need hospitalization. You need intervention. You need someone, it's that bad. Whereas hypomania, 4 consecutive days present most of those days. So they could last longer or shorter. And typically with hypomania, there's not necessarily that you'll have to go, get some kind of treatment for it. Great question.
Can that person function on a daily basis? I mean, if you're out from one to the other, I mean, how can you live in, I
you
Yeah.
get that high, and then you get that low, and you
Right.
can't function.
Right. It's really difficult. Imagine, like, yeah, maybe you have a good job, and then you're depressed, and you're not going to work, or you're going to work, you're not getting your work done, and then you become manic, and you're like, I don't need that job. I'm going to go be a singer-songwriter, and so medication, really helpful. There's treatments for bipolar as well, but medication's really helpful. Keeps those highs not so high and those lows not so low. So, and again, I'll show a graph in a minute, but essentially, all of us in our lives, like if this is normal, and this is, what's normal? But if this is like average, what's average? And this is sad, so, life kind of is like this, It might be, you hit a bad point in life or you hit a good point in life. But what we don't want is this, right? That's not what we want. And so, or even this, we don't want you go up and you're in the middle for a little bit and down. And so what the meds do is they help it get kind of right in the middle there. That's a great question. They've changed over time. I'm trying. There's one coming to my mind, but I don't know if it's right. But I got it right here. There's a few. Zyprexa, Seroquel. Seroquel is an antipsychotic. I think Zyprexa is an antidepressant. I think. Risperdal. Abilify is good because Abilify is really good for hallucinations and delusions, which you could potentially have you can have those. A lot of these diagnoses will have modifiers that you could say with psychotic features or with anxious distress or with this. So people could be bipolar and also have psychotic features. So Geodon's another one, and then Clozaril or clozapine. So and there's good therapies for them. Like I do a lot of cognitive behavioral therapy, which is really good. Mindfulness-based therapy is really good. How do you make good decisions when you're, be more mindful of your thoughts when you're manic so you don't make rash decisions? Did we cover the last one? Oh yeah, so increase love and affection for others. So I have a client who came in a couple days ago, and she goes, so she says she's bipolar, and I've never seen a manic phase from her, so I was kind of trying to feel it out to see is she really bipolar or not. And when I'd asked her my questions in the assessment, it was kind of on the fence. I wasn't sure. And so I said to her, she'd been having a lot of issues with her sister. She was living with her sister because she didn't have a place to live, and she was trying to stay sober from drugs and alcohol. And her sister and her had been fighting. It was a mess. Her sister kicked a row and a bunch of problems. She came in one day. She sat down in my chair, and she's talking all about her life, and she goes, and my sister. Oh, I just love my sister. And I was like, ooh, that clued me in. That clued me in. It could just be they're in a better place than they were, but that clued me in a little bit that maybe there's something else going on. So, they were having lots of issues for a long time, and all of a sudden it was almost this elatedness about how much I love my sister. And then tell-all for this too is after the mania, it's followed by a deep bout of depression. So that's what this graph kind of shows. So unipolar would be like a depression, like a person with a depression diagnosis. So you see this is that normal that we were talking about here, and then happy is up here and sad. So you'll get a deep dip here and then another dip here. Whereas this is bipolar here, where you have these highs and followed by a deep low. And the next one I like even more. You have bipolar 1, which is where you have the manic, which I said, or like full mania, which is worse, followed by a deep all the way down to depression. Bipolar 2, you just go to hypomania, so not as bad, and it's a little shorter. You see the length of time is less. You drop down. This last one's called cyclothymia. Some people have started calling it bipolar 3, but it's essentially where you go to mania and your depression isn't as much, and you cycle through them a lot quicker. I've known a few people in my personal life that I think have different versions of these, but one who has cyclothymia, and overall they functioned okay because the highs aren't as high and the lows aren't as lows, but it's still really difficult disorder to have. Any questions about bipolar, what we talked about so far? We're almost done. We'll wrap up soon.
You just mentioned disorder. You started to say disease, but then said disorder.
Yeah.
So, is it a disorder, or do they medically see that as a disease, or?
Great question. In my opinion, I would say both, and I think we're moving in a direction where we're starting to see mental health as the same, the same as other types of diseases. I use disorder more than disease, but one of the things we talk about, like for example, alcohol use disorder or alcoholism, we're really moving into or any addiction into the disease model, to where it's not there's some fault in some person's character, they have a disease. Like I could have type 2 diabetes potentially because I mistreated my body a certain way for a long time, and now I have a disease that I have to take care of. Well, it could be the same with alcoholism. I mistreated my body and my mind in a way for a certain amount of time, and now I have a disease as a result of it. I'm not a bad person. I just have a disease. I have an issue. But I use those both, but I think I use disorder more than disease. Yeah. Any other questions? Yeah.
Normal people have ups and downs, like that cyclomania, you go up and down.
Yeah.
Your life isn't the same all the time, hopefully.
Right, and so that's good. What we don't want to do is pathologize everybody, right? Because that's the risk of this, is that we could assign labels to everybody. And so when I drew this, that's kind of what I was hoping to communicate, is that life does have its ups and downs. And like I would say in my life, I've definitely had my ups and I've definitely had my downs, but I don't feel like I've had mania or hypomania. And so that's the difference. If you're hitting these things where you're doing some of these things, and it's negatively affecting your life in a way, right? So that was one of the first things we talked about, is how is it affecting your life? Is it affecting your life in a clinically significant negative way? Then that's something that we would call, that we would look into as being a disorder, being kind of outside a normal outlier of what we want in life. But yeah, you're right. Life has its ups and downs. We want to be careful not to over-diagnose everyone because they go through stuff. And there are things, I have clients, I have to educate them too about like normal anxiety. There are things that can be anxiety-provoking for people. So speaking in front of people doesn't make me anxious, because I teach and I train people a lot, but I know people get really anxious when they get in front, going to talk in front of people. I wouldn't necessarily diagnose you with anxiety, with an anxiety disorder. You got to get in front and talk in front of a bunch of people, and you're not used to it, and that's anxiety. You have anxiety about it. So that's a good point to remember, not to overdo it. All right, I want to be mindful of time. I know people got stuff to do. So maybe just think to yourself or write on your paper one takeaway for the bipolar that you'll remember, so that way you carry with you one thing. Any other questions or things I can help with before we're done? I forgot business cards, but if you have any questions, I guess the best email would be paul.kiger. My last name's like Tiger, but with a K, at mercyhealth.com. I have 6 email addresses I check every day, so this is the one. I know, I work at a lot of different organizations and do a lot of different things, so this is the one you probably get the best response from.